Bozo. This is a way to say hello or a formal type of greeting in Potawatomi. My name is Adriana Black, and I am the founding director to the Odehmenan Health Equity Center, Odeh Center for short. On behalf of my team, I want to welcome you all to our third Odehmenan Health Equity Speaker Series, The Haunted Curriculum and Health Professions Education. And this program is currently being recorded. For a bit of background, Odehmenan translates to this heart of ours in Potawatomi. The Potawatomi people are one of the original peoples of the Chicagoland area and one of the Three Fires Confederacy nations who know this area as their ancestral home. I want to give full credit, appreciation, and gratitude to Donald Parrott, our friend, language expert, and elder who has been on the journey of creating this space since its inception and has provided all translations. Today, I am joined by Dr. David Ansari from the University of Illinois College of Medicine. Over the course of the Odeh Center's first year, we will be spotlighting the 7 health sciences schools and colleges in this series, College of Medicine is the third to be spotlighted. Stay tuned for the College of Nursing next month with Dr. Sarah Aboud. Dr. David Ansari is an assistant professor in the Department of Medical Education at the University of Illinois College of Medicine and a faculty affiliate in the Department of Anthropology. A cultural and medical anthropologist, his research and teaching interests encompass the social determinants of mental health, race and belonging, and health professions education. He has published in SSM Mental Health, Transcultural Psychiatry, Medicine Anthropology Theory, Culture, Health, and Sexuality, and in Health and Social Care in Community. He completed his PhD at the University of Chicago and his Master's of Science at the London School of Economics. Prior to completing his graduate studies, he was a Fulbright research scholar in Senegal and a post-baccalaureate intramural research training awardee at the National Institute on Aging. He has held academic positions at Washington University in St. Louis, Sciences Po, and King's College in London. Without further ado, Dr. Ansari.
Great. Thank you so much, Adriana, for that introduction. And thank you to Adriana, Cassandra, Samina, and the whole team here at the Odehmenan Health Equity Center for this opportunity to share my work. I'm really excited to be a part of this very cool series. So I'm an anthropologist by training, and my research focuses on the social determinants of mental health, which includes the mental health and well-being of health professionals, and health profession students. And prior to coming to the U of I College of Medicine, I was in an anthropology department at Washington University in St. Louis. And I taught a class there called Global Mental Health, which focused on equity and access to mental health care in a variety of geographic contexts. And the class, perhaps unsurprisingly, drew a lot of students who were pre-med and psychology majors. And I remember one student who was a psych major who came up to me after class and told me how much they liked global mental health because they had learned about psychopathology in their psychology classes. But in my class, they learned about psychopathology when life happens. And so I tell the story because I think it's fascinating to think about the clinical and diagnostic features of illness, whether it's mental or physical, in one space, and then to look at these same features when life happens. So did I do something? Oh, is that better? Okay, sorry. So my presentation today is from my forthcoming book, The Next Generation of Therapists, Orchestrating Belonging and Mental Health Care in France, which examines how multiple generations of psychotherapists reflect on, is it the same thing with the sound? Okay, cool. My book examines how multiple generations of psychotherapists reflect on migration, race, religion, and Frenchness as they support patients whose experiences of mental distress have been shaped by migration and displacement. My book draws on interviews and observation data I collected at mental health clinics for refugees and asylum seekers in Paris. These were clinical and therapeutic spaces, but they were also spaces of training for clinical psychology students and residents in psychiatry. The clinics were also unique spaces to learn about mental illness because forms of violence which included displacement, conflict, sexual violence, being unhoused, and threats of deportation, were central to the experiences of mental distress among patients. These clinics also presented another fascinating scenario. Many of the senior mental health professionals who were psychiatrists and psychologists had come to France as immigrants themselves. And many of those who were training to become a clinical psychologist or a psychiatrist were born in France, but it was their parents who had come to France as immigrants. And over the course of carrying out this project, I became very taken with the frictions between generations of therapists, particularly in terms of how they articulated what it means to belong in France. So, as an anthropologist, I was interested in examining the formation and performance of psychiatric and lived expertise, as well as the power relations that authorize certain forms of knowing and being over others. So, the title of my talk today and the focus is on the haunted curriculum, or what I'm calling the haunted curriculum, which helps us understand how the development of clinical expertise involves learning to grapple with forms of adversity, oppression, and injustice. And as learners and health professions undergo processes of becoming experts, they also witness the suffering of patients or they may experience it themselves. The haunted curriculum builds on what many in health professions education have referred to as the hidden curriculum to account for the subtle and informal ways of learning to become a clinician. But in this case, where the transmission of the culture of medicine or health professions involves countering or reproducing forms of injustice and adversity. So, in thinking about haunting, I turn to the scholarship of Derrida, Jacques Derrida, the late French philosopher, who wrote about ghosts and specters and had this term hauntology, which brings together haunting and ontology. And this helps us understand how atemporal pasts and incomplete futures continue to haunt the present. So, thinking of the clinics in my book as haunted is generative because it allows us to consider how oppression and injustice emerge in unexpected ways, and the ways that actors within these sites engage with oppression. But in addition to Derrida, I also turn to the sociologist Avery Gordon, who has detailed how haunting is a kind of animated state where an unresolved form of violence is making itself known, either directly or indirectly. And Gordon calls on us to engage with ghosts, stating that, and I quote, conjuring is a particular form of calling up and calling out the forces that make things what they are in order to fix and transform a troubling situation. So I started thinking about the haunted curriculum in my research among budding psychiatrists and psychologists who were undergoing apprenticeships in mental health clinics that support immigrants and refugees and non-Francophone individuals. Um, these apprentice therapists, as I referred to them, learned about psychopathology, but they also witnessed how the psychopathology they learned about in their course text was shaped by a range of social, culture, political, and even magical forces. And my thinking about the haunted curriculum is also based on being an anthropologist in a medical school and reflecting on the ways that forms of oppression and injustice are not just things that medical and health professions learn or occasionally witness or experience, but rather are central to their development of expertise and professional identity. So, for the most part, I'll focus on the haunted curriculum in mental health clinics in France, but I'll also wrap up by discussing the broader appeal of this concept by reflecting on how it might help us think about additional dimensions of health professions education. And to do this, I'll talk about two new projects that I'm working on that draw on the experience of medical students concerning representation and simulation, and also among medical students who identify as first generation. So, when I say the haunted curriculum, I mean the following. Learners in the health professions, and in this case, in my book project in France, up and coming psychotherapists encounter patients whose illness was shaped by forms of violence or oppression or injustice. So, in this sense, we can think of haunting as metaphorical. But I also mean that learners actually encountered patients who saw ghosts and who were afflicted by spirits. So, here we can think of haunting as representational, where for patients, haunting might be very real, but for others, it could be a source of skepticism. And third, I also mean that learners reflect on and engage with some of the more pernicious or exclusionary aspects of medical training and training in HPE. So, my talk today is based on ethnographic research that I conducted in 4 mental health clinics in Paris that support immigrants and refugees and non Francophone patients. And these were also sites of training for clinical psychologists and psychiatrists who undertook apprenticeships that lasted anywhere from a few months to an academic year. And as a researcher in these clinics, I was given the same role as some of the apprentice therapists, meaning I observed therapy sessions, I took notes, and I was occasionally called upon to speak. And I also conducted 65 interviews with psychologists, psychiatrists, and apprentice therapists. So I want to start with one of the earliest clinical sessions that I observed in my research, which was led by a psychiatrist whom I call Samir, for a woman who I call Maimouna, who is a 22-year-old woman and seeking asylum in France after fleeing the West African country of Guinea. Also present was Laetitia, who was a graduate student in psychology and who was apprenticing for a few months at the clinic. So Maimouna had arrived in France a few months prior with her 1.5-year-old son and was living in a temporary housing center for asylum seekers and receiving psychiatric treatment. Maimouna had come to this clinic with her social worker, who was from a network of medical and mental health centers who support asylum seekers, because they wanted to consult this clinic staff about Maimouna's symptoms of psychosis. Now, while her social worker and her psychiatrist and the nurse who gave Maimouna her daily medications considered her condition to be due to psychosis, Maimouna had another explanation. In the therapy session with Samir, Maimouna explained that she was deeply afraid of her husband, a powerful businessman who had tried to kill her and her son upon learning of an extramarital affair. Her husband, she said, was a sorcerer and could appear whenever he wanted, including in her dreams. And she also reported that she had these apparitions that she had during the day and also in her dreams stopped when she took her medication. Samir assured Maimouna that she and her son were now safe and that her husband could not get to them. With a dry sense of humor, he told Maimouna that her husband could not possibly be both a businessman and a sorcerer. And Samir added that while sorcery might work in Guinea, he said that it doesn't work in France. No, Maimouna said, he can appear anytime and anywhere, even here. None of us is safe. And just as she said this, there was a knock at the door, causing all of us to jump up and look at each other. And the door opened a crack, and thankfully it was just one of the medical assistants and not Maimouna's husband. Though for a second, we all kind of wondered if it might be him. Maimouna asked Samir if he believed in sorcery, to which he responded, "It doesn't matter what I believe. It matters what you believe. What is important is that you continue to take your medication," referring to the two antipsychotics and two antidepressants that she had been prescribed. So this interaction between Maimouna and Samir was one that clinical psychology students like Laetitia witnessed during their apprenticeship in this clinic. So learning to provide mental health care required the skilled ability to immerse oneself into a patient's world and to witness how their experiences of distress were shaped by family trauma, displacement, precarity, and persistent haunting. Care also required a therapeutic vision that recognized biomedical diagnoses and prescriptions while also understanding the reality of sorcery as an explanation for patients. So an ethnographic observer like me and an apprentice therapist like Laetitia needed to recognize how a therapeutic vision for care extended beyond an office and a clinic, since it required the dynamic coordination across multiple actors, sites, and scales. The haunted curriculum not only encouraged us to think about how the training of therapists like Laetitia involved attending to forms of violence that afflict people like Maimouna, but also what it was like for apprentice therapists to accumulate clinical and caring skills that were haunted by legacies of racism and colonialism. The ghosts that I'm going to talk about include actual hauntings, such as Maimouna's husband, as well as those that were more metaphorical, such as forms of oppression and indignity that lurked in the shadows of these clinics and that affected patients and therapists alike. Apprenticeship helps us understand the formation of clinical expertise and how it's haunted, because it's through apprenticeship that tacit knowledge, intuitions, skills, and judgments become embodied, and where novices are absorbed into communities of practice and transformed into experts. Not everyone experiences clinical apprenticeship or the hidden curriculum in the same way. So the haunted curriculum helps us to theorize how the performance of clinical expertise both extends and resists forms of injustice. So this image is borrowed from an NPR article about using podcasts to teach about migration in classes. And as someone who's taught classes about migration, I agree that podcasts are great for doing that. So what you see here are three individuals who appear to be Muslim women based on their appearances. The woman on the left appears to be a doctor based on her white coat and stethoscope. The woman in the middle appears to be stretching across two continents. And the women appeared to age from left to right as we go from left to right. And I think this image nicely illustrates how healthcare providers support people whose health and mental health have been impacted by migration and how they reflect on their own experiences of belonging as they do so. So, my research draws from extensive fieldwork conducted among people who were descendants of immigrants and who were also becoming therapists who wish to support immigrant and minority patients. And the clinics in my book took an approach called transcultural psychiatry, which was developed in the late 1990s and early 2000s and is currently considered one of the leading approaches in providing psychotherapy for immigrant and non Francophone people who might be excluded from other public mental health services. So, in transcultural psychiatry, immigrants and refugees are heard both in terms of their spoken language, but also in terms of their representations of mental illness, which may not easily map onto diagnostic categories. So, this vibrant image that you see here is from the cover of a transcultural psychiatry journal, which features research and clinical case studies in France. And so what you see here is a group of people who are seated in a kind of oval shape. And the two figures at the top appear to be women who are holding hands, and there appears to be a family at the top right. And we can also see circles of text with Arabic script, and we even see writing in French on the dresses of the two women at the top. And so I present this image to highlight two important aspects of transcultural psychiatry. First, transcultural psychiatry is conducted in groups, where a principal therapist leads the group and interacts directly with the patient and their family. And second, the group seems to be somewhat racially ambiguous, with the exception of the family in the top right, which is clearly Black. So this takes place in France, where data on race and ethnicity are not officially collected, and where identifying in terms of race and religion is reserved for private life. So people instead will speak of cultures and origins instead of race, even when the terms like cultures and origins are used clearly in a racialized manner. So while transcultural psychiatry is directed towards immigrants and their descendants and not explicitly people of color, it is often almost exclusively people of color who come to these groups for therapy. So, transcultural psychiatry sessions are conducted in groups, meaning a group of psychologists and psychiatrists receives a single person as a patient. So, I wanted that to sink in for a second, because while we might think of group therapy as involving multiple people who are going for therapy, this is actually a group of multiple therapists. So, anyone who's had experience of therapy might find this to be particularly jarring to walk into a room full of people. And previous research on transcultural psychiatry has emphasized the importance of culturally diverse therapy teams and the ways that therapists' own diversity could permit patients to open up during therapy sessions. And the therapy teams within these settings were kind of like multi generational families. At times, these different generations of therapists had very different ideas about how to conceptualize forms of belonging and diversity, and these different ideas could become quite heated. The family-like generational structure of therapeutic inskillment in these clinics is essential to understanding how aspects of the haunted curriculum are absorbed and contested. So while some therapists, notably the supervising therapists, came to France as immigrants, the apprentice therapists were primarily born in France, and it was their parents or grandparents who came as immigrants. And these different generations differently experience processes of racialization, belonging, and Frenchness. So I'd like to walk you through one example uh, of one of these therapy groups that convened to receive Aisha, who was a woman in her early 30s, whose psychiatrist referred her following 1 month hospitalization for being in a manic state. And the psychiatrist had diagnosed her with paranoid schizophrenia and also mentioned that Aisha's brother had died a few years prior in the very same hospital where she was hospitalized. And Aisha was accompanied by her mother and her older sister, who understandably were visibly shocked by the large group. Anna, the psychologist who was the principal therapist, led the group by speaking with Aisha and her family, while the other therapists in the room would only listen and speak when Anna called on them. Anna told Aisha that the therapy group was a space where people could discuss being in France while also being from elsewhere. So, to illustrate this, she said that she was from Chile, that Mai Sheng, another one of the psychologists, was from China, and that I was from the United States. Anna introduced the rest of the group and a professional interpreter the clinic had hired, who, like Aisha's mother, was from Algeria and spoke Arabic and Berber. And during the session, the group and the family discussed their memories of life in Algeria, the extended family that they left behind, their arrival in France, and the death of their brother. Maisheng, noting that all three women were dressed in black, commented on their outfits and how these outfits made her think of an image of a constellation where some stars are bright and some stars are dark, and the constellation requires both of these stars. Aisha had remained silent but spoke in a way that indicated her lack of enthusiasm for this group therapy session. She said, "What is the purpose of these sessions?" Aisha stated that Anna asked a lot of questions of her mother, questions that were dumb and irrelevant, she said. Aisha also stated that her family did not need an interpreter since she was born in France and her mother spoke fluent French. Anna defended having an interpreter, saying, and I quote, "It's like music to hear people speaking in their first language," unquote. Sensing Aisha's anger, Anna asked about her hospitalization, and to this, Aisha seemed more receptive. Anna asked Aisha's mother about Aisha's diagnosis, and Aisha's mother doubted the diagnosis of schizophrenia and instead suggested that the evil eye might be responsible. Aisha, on the other hand, stated that she didn't believe in the evil eye and instead insisted that she had schizophrenia. Anna turned to Sarah, who was an apprentice therapist in the group, who said that parents and their children do not necessarily agree about what causes a particular situation. And Aisha smiled at this response, but didn't say anything herself. So, not wanting to cover more material than they could, sufficiently discuss in the remaining time, Anna stated that they proceed slowly in this clinic and suggested that they meet again. So, in this case, haunting is generative here because apprentice therapists in this group learned not only about the lived experience of schizophrenia, but they also learned about the evil eye as an alternative explanation for distress, how Aisha's hospitalization conjured painful memories of her brother who died in the very same space, and how language interpretation could be seen as music by some, while suggesting to others they were not French enough. Anna explained to me that being the principal therapist was akin to conducting an orchestra, saying, when you're the principal therapist, you need to see how it evolves, what is happening with the patient, how they feel, where the flow of the conversation is going, and how the group echoes what's going on, how and to whom to call upon because you know the group by heart. It's like directing an orchestra. So just like a conductor relies on certain musicians or sections at a certain point in a symphony, principal therapists relied on certain dispositions of the other therapists at specific points during therapy sessions. Conducting or orchestrating therapy meant that apprentice therapists not only accumulated clinical and caring expertise, but they needed to do so in a way that was attuned with a therapy group. Because these therapy groups supported displaced and non Francophone populations, and because of the diversity of the therapists themselves, apprentice therapists also needed to learn to summon forms of belonging that resonated and that were felicitous with a group. Orchestrating therapy meant that therapists, both apprentice and supervise it, needed to also summon distant and potentially painful pasts. And summoning the past became violent for some therapists when they were used in tokenistic ways in the group and when the authenticity of therapists' experiences and words were questioned. So, supervising therapists selected apprentice therapists based on their migration experiences and the physical diversity that they could bring to the group. Patrick, who is one of the psychiatrists, emphasized the importance of visible diversity in therapy groups in these transcultural clinics, stating, "I think that different skin colors are important, meaning that if everyone is white, especially here in France, where there is a history, I think there needs to be different skin colors to permit multiple ways of identifying." I say that and I know how that can make people react, but I think it's an important point. There needs to be different phenotypes because if everybody looks like me, it will not work. So, Patrick, pointing to his own whiteness, suggested that these therapy groups, which were for immigrant and minority patients in France, would not work if all the therapists were white. This was particularly crucial given France's colonial history and that many of the patients came from former French colonies. It was the apprentice therapists who brought the visible diversity and legitimacy to these clinics. And apprentices were selected because of their skin colors and migration backgrounds, and they also needed to be present and visible in the therapy groups. Being visible meant that they would be introduced as being from a particular country, kind of like how Aisha introduced Maisheng as being from China and introduced me as being from the United States. And at the beginning of every therapy session, such as the one with Aisha, the principal therapist who was leading the group would introduce everyone in the group, stating their name, function, and country of origin. So for some, this was an exciting and affirmative exercise that allowed them to explore their ancestry and their families' experiences of migration. But some apprentice therapists felt disconnected from the forms of belonging that mattered most to them. For instance, Muriel, who is an apprentice therapist who was born in France, but whose father came to France as an immigrant from the Central African Republic, said, "They asked me, 'Do you speak the language?' And it really frustrated me because I don't speak the language of my father. I felt a bit like an exotic object. If you ask me about my childhood in France, it's easy. I'll tell you about going to the boulangerie with my parents and the smell of croissants and pain au chocolat. I have memories of that. They said, your father immigrated to France, but I can talk about leaving my parents' house and moving to Paris. It's not that far in terms of distance, but it's still another world." Therapists like Muriel were expected to enact specific forms of belonging over others and to be in certain ways that did not always seem fitting. When Anna likened leading the therapy group to directing an orchestra, what she meant was that the principal therapist called on other therapists in the group to share a reaction, an image, and expression. So Maisheng's example was giving an image of a constellation, and Sarah's was the observation that parents and their children do not always agree. And these were some of the examples of things that therapists would share. But some therapists explicitly invoke their ancestry or their cultures of origin before sharing an image or reaction. And they could even be corrected if their imagery or their representations were considered by their supervisors or their peers to be inauthentic. So in one instance, Rohit, who was one of the apprentice therapists, questioned the authenticity of the comments of Josephine, another apprentice therapist. And he said, "I remember one example. Josephine said, in my culture, in Tunisia, one says that the soul," and then she started talking about philosophy, which has got nothing to do with culture or Tunisia. It's almost saying that it's universal. Later on, I said, "What you said isn't in Tunisia, it's everywhere." Rohit's comments not only divorced philosophy from culture, but they also suggested that one's experience or representations in or of Tunisia could not also exist simultaneously elsewhere. And Josephine's images were not authentically Tunisian, at least from Rohit's point of view. Separately, Josephine had conveyed to me that she had never been to Tunisia and found speaking about her Tunisianness to be very uncomfortable. She would have much rather spoken about her faith as a Jewish woman, particularly at a very intense time. This was in 2015, following terrorist attacks that happened at the Charlie Hebdo magazine headquarters and terrorist attacks at a kosher supermarket. But she felt compelled to speak about Tunisia during these therapy sessions because that's what her supervisors wanted from her. So, providing mental health care for people like Aisha not only required the clinical expertise of individual therapists, but also the careful orchestration of therapy. Therapists like Anna directed the group, but orchestrating therapy for people like Aisha involved the social and affective dimensions of the group and even the spiritual world. The accumulation of clinical and caring expertise among apprentice therapists in the setting involved becoming attuned to the others in the group and summoning one's own images and reflections. Clinical unskillment in this setting also meant that apprentice therapists witness how a person's hospital or therapeutic trajectory was haunted by violence, such as losing a brother or a son, and indignities, such as having a language interpreter thrust on them. Clinical unskillment also required therapists to enact forms of belonging to represent difference and diversity in terms of culture and nation. And this had the consequence of suppressing ways of belonging in terms of religion, for instance, as well as multiple or simultaneous ways of belonging, since apprentices like Muriel were seen by their supervisors in terms of migration rather than in terms of being born in France or having a multicultural French experience. So one of the claims that I make in this project is that the haunted curriculum in transcultural psychiatry inadvertently reinforces singular notions of Frenchness, primarily white Frenchness, that exclude the experiences of French people of color. And indeed, someone like Muriel could only be legible in a space like this as someone who's of Central African origin and not a French woman of color. And Josephine was perceived as not Tunisian enough because her representations of Tunisia also happened to exist elsewhere. And their experiences were shared by other descendants of immigrants in France who might demonstrate multiple ways of being and belonging, but who are otherwise potentially perceived as not being French enough. So the haunted curriculum helps us to engage with a range of ghosts. These could be things like sorcery or the evil eye, forms of violence that happen outside and inside the clinic, and the ways that some ways of knowing haunt other ways of knowing. Returning to the story of Maimuna that I opened this talk with, one reading of the story is that Samir, the psychiatrist, understood how Maimuna processed her distress even if he didn't believe in sorcery. As he told Maimuna, it didn't matter what he believed, and he did not try to convince her that her distress was due to any other cause. But another more cynical reading of the story is that while Samir's speech suggested that biomedical psychiatry and sorcery were both given consideration in the space of the clinic, Samir's orders to continue taking her medication indicate that there was only one valid course of action, and perhaps Samir's openness to Maimuna's concerns was to ensure her compliance. So I'd like to think with you about the reach of the haunted curriculum beyond this example from psychiatry in France to consider what it brings to medical and health professions training more broadly. I've been grateful to work with a collective of anthropologists and health professions education researchers at institutions in the US and Canada and New Zealand who are interested in how racism and ableism are perpetuated and challenged in medical and health professions education. We actually organized a really cool panel in November that was about the haunted curriculum. And from that, we've also been able to launch a special issue of the journal Social Science and Medicine called Beyond the Hidden Curriculum. So we're very excited about being able to share some of this work. Um, but more recently, I have been thinking about what the haunted curriculum can add in terms of simulation training for medical students. So, simulation training, which includes standardized and simulated patients, as well as technology based or enhanced simulation, provides health professions learners access to immersive education not readily available to them. And in a manner that doesn't harm patients. And simulation also supports learners to develop dispositions and professional identity integration. And in simulated encounters, learners can reflect on their biases and prejudices as they develop various skills around communication and empathy. And simulation has the potential to teach skills concerning justice, equity, diversity, inclusion, and anti racism. So, working with Professor Christine Park, I've developed a study among medical students in each year of medical school, simulation instructors, and simulation professionals on each campus in the U of I College of Medicine. And I'm curious about how simulation can be used to cultivate what many consider to be softer skills like empathy, which are perhaps better thought of as dispositions and forms of attunement than skills. I'm also interested in the way that simulation may address issues of injustice in medicine as well as potentially reproduce these injustices. So data for this data collection is ongoing, but we've been able to speak with multiple medical students across the campuses who have these conversations are primarily focused on the ways that they relate to simulation scenarios and to the professionals who help enact these scenarios. And while simulation can be used to teach about diversity, our medical school boasts having one of the most diverse medical student bodies in the country, which is significant because it suggests that the rich experiences that students bring to simulation and that they may already have the lived experience or expertise that simulation can potentially cultivate. So the students with whom I spoke detailed the extent to which simulation aligned with their lived experiences and what they witnessed in their clinical encounters. One student, who I call Rick, a first year medical student who identifies as Black, stated, and I quote, I think there could be more discussion of inequities, barriers, and diversity as part of SIM. And I feel like it comes up in my everyday life, but maybe that's not the case for everybody. And so, at least trying to get some familiarity with the topic in a comfortable environment, I feel like it would make people feel better. Medical students like Rick are thinking about how to integrate or how simulation aligns with their lived experiences and what they witness or will eventually witness in the clinic. They also recognize the challenges that simulation scenarios and professionals that professionals do not always represent the populations that they'll encounter in their clinical experiences. Another medical student, Catherine, who's a fourth year student, suggested that cases address situations that nudge learners to think beyond the immediate procedure in front of them, stating, let's have a theme where a patient comes from a financially low income background. And how do we address that sort of situation? Or a patient that doesn't speak English. How do we address that situation? Or a patient who lost faith in the US healthcare system. How do we address that situation? Those are the things that I think they should focus on instead of we have a patient with chest pain. How do we address chest pain? Some simulation scenarios could make students feel more self-conscious about their own identities. Linda, who's a first-year student, recounted saying, "Most of our sims I feel disconnected to or disconnected with. A lot of them tend to be older white males or older white ladies who enjoy drinking on the weekends, and I can't really relate. I'm conscious of my own identity in front of my SPs, my simulated patients or standardized patients, because I'm not sure how they're perceiving me if there's any bias. Sometimes I feel like if I were to have more experiences with people of color or people from other different backgrounds, I'd be able to connect with them more based on our similarities. And I could be like, oh, yeah, I can understand this or how you're feeling with this." So it's important to note here, which you can't tell from this quote, that Linda also was a Muslim presenting woman who wore a headscarf. And this was important in terms of these conversations that she would have with standardized patients. And this student, Linda's perspective might sound quite critical and difficult for some to hear. And my objective in sharing her perspective is not to be critical, but rather to raise something that I see as very important in her comment. She, of course, was not suggesting that she only wanted to see patients, standardized or eventual patients that she shared similarities with, or that she could not provide care for those patients with whom she struggled to identify. Rather, she pointed to the additional labor that she, as a Muslim presenting woman of color, had to perform in this scenario that other students might not have to. So I want to be clear that when I'm talking about the haunted curriculum in this context of simulation, I'm not suggesting that simulation is haunted, though I would very much welcome conversations around artfully conjuring mannequins. Um, and I don't want to suggest that the context of learning through simulation are negative. What I do suggest, however, is that there's a lot of opportunity here to examine how the lived experience and affective experiences of learners that have historically been overlooked can be constructively examined in simulation. This is also a great opportunity to mention that ghosts and haunting are not necessarily harmful or wicked. Quite the opposite. I'm reminded of the wise words of Catherine Belling, who's at Northwestern, who has written about horror in medicine, and who has identified that ghosts can be teachers. And I'm also reminded of the guidance of Avery Gordon, who suggests that ghosts represent a loss, but also a future possibility. And this is why the haunted curriculum is more generative than the hidden curriculum. The hidden curriculum, which suggests that if we pull back the curtain and render things more explicit, this will improve environments and experiences of learners. The haunted curriculum is less concerned about uncovering and more about engaging and sitting with what we might consider to be part of the shadow side of medical training. Um, so I want to talk about another project that I'm working on, this last project that I want to share with you before wrapping up. Um, which I'm working on with Joanna Michael and the folks from the urban medicine program. And we're also collaborating with a medical student who's also a first generation medical student, who's one of our collaborators and will be one of our authors. And so kind of like the other study, data collection is also ongoing, but we're conducting interviews with medical students across all 3 campuses who identify as the first in their families to attend medical school. And our interviews have focused on, what drew these students to medicine, their identities as first generation medical students, the challenges they face, and what they envision their future care to look like. And while the hidden curriculum is a very helpful concept in thinking about all that is new and unfamiliar that first generation medical students experience, in applying to medical school and in thriving in medical school, I suggest that the haunted curriculum actually helps us dig much more into the understanding of the multidimensional experiences of students. So one student that I call Phil detailed feelings of otherness that came from his peers, his family, and faculty. Again, I want to emphasize that this is not to be critical, but rather to give voice to the complex experiences of students. So Phil was not only a first generation medical school, but he also had a non-traditional background. And he talked about learning all the steps to prepare himself to become a competitive medical student or medical school applicant, and doing this on his own with minimal guidance. He shared this experience with some of his fellow students, whose reaction created what he called a feeling of otherness, saying, "I tried talking about some of those experiences with a couple of classmates, and they were just kind of looking at me like, 'Oh my gosh, what are you talking about? What do you mean you had to figure it out? Isn't it just so obvious?' Well, no way, it's not obvious. My experiences are not their experiences, and I think that does contribute to a sense of otherness." So in our conversation, Phil continued discussing the reactions he had from his family, stating, when we don't have additional support from family because our families don't know the system. They don't know the struggle of going through medical school. It's difficult for me to reach out to them and be like, "Hey, I'm going through this thing. It's really hard." And they're like, "Well, yeah, you knew med school was going to be hard." So I quote Phil at length because he also told me about how he worked while he was in medical school to support himself. And when he raised the fact that he worked to support himself with faculty, he got this reaction saying, I had a conversation with one of the faculty about that, and they were just like, "Why are you working through medical school?" And I said, "I don't have any parents to help me, so I'm working." So I was deeply appreciative of what Phil shared with me because it demonstrates the challenges that first generation students face, but it also revealed how experiences of feeling othered came from multiple sources. And Phil also detailed how his lived experience would ultimately help him connect more naturally with his future patients to be a better doctor. Phil shared this with me, saying, I might be talking out of my behind here, but I think I might be able to relate with a certain group of patients a little more naturally. And I only say that because of my personal interactions with some of my classmates when I've tried to talk about real life issues like going to food banks, what it feels like to not have enough money to eat for the rest of the week, and what it feels like to not be able to pay for my prescriptions, because I've been there before. I think I might relate a little bit easier. The first gens, meaning the first generation students, don't have as much money. Usually they don't come into it with as much capital, but it's not just financial, it's social. They, referring to other classmates who are not first generation, they know doctors, they know things. And most of our patients do not come from families and grow up with doctors as a parent or as parents. And most patients have challenges that I think I've had. So I really appreciated this perspective from Phil because he clearly articulated adverse experiences that he had that he would likely share with his future patients. But he also turned ways of knowing and experience on their head, contrasting the kind of know-how that he and his peers possessed. This is one of the reasons why I find the haunted curriculum to be so much more evocative than the hidden curriculum. Phil's statement suggests that rather than just needing to reveal things that might not be readily obvious to him and his first generation medical student peers, but he's directly engaging with the experiences of adversity and oppression that have been formative for him and that will likely make him better suited to care for his patients. So I want to share one more excerpt from an interview with you before wrapping up. And this is an interview I conducted with someone I'm calling Victoria, who told me she pursued a path to medicine because of her early experiences of translating for her mother during doctor's visits, and she wanted to extend that experience to help others who might not be able to easily access healthcare services due to language differences. So, due to her, or during our interview, she said she discussed the importance of mentorship and being there for other students, stating, I also want to be a role model for younger Latino students, other students of color in general. Um, just knowing the difficulty that I had when I went through and how hard it was for me, I want to give back. And there have also been multiple mentoring opportunities. So whenever there's one that pops up, I always want to sign up. And I always want to offer my advice or my contact information for other students, and I want to be there to help in any way that I can. I feel like you always want to see somebody who's been through what you have been through and have been able to become successful. So Victoria had formative experiences that inspired her to pursue a career in medicine, and like Phil, experienced her fair share of challenges. What her perspective adds is a sense of pride that she felt as a first generation medical student and wanting to use her experiences to mentor other students. Um, I don't quote her here, but in another part of her interview, she detailed that whenever she had met someone who was also a first generation, whether they're in medicine or another field, she knew how much harder that they had to work. And I share this forthcoming material from our study with first generation students in medicine, not to illustrate all that might be hidden from them, but rather to demonstrate that the experiences that they had, including those that might be marked by adversity and oppression, were central to their becoming doctors and their future patient care. So, to wrap up, the experiences of oppression or adversity or injustice or even violence that students witness or experience themselves are deeply formative. Drawing these examples together, these disparate examples from psychotherapy for immigrants and refugees in France to medical students' perceptions of representation and simulation to first generation medical students' experiences, these examples show that it's not just that there's illness or mental illness and then there's illness or mental illness in contexts when life happens, as that student told me. Instead, there is not just clinical training and then there's clinical training when there's much that's hidden or tacit. The haunted curriculum, on the other hand, helps us to understand how the experiences of oppression and adversity are really central to learning, and this is not necessarily a bad thing, because these examples, which are quite varied, demonstrates what learners bring to the table and how their lived and affective experiences enrich training and patient care. So thank you so much to all of you who are here and on Zoom.
Thank you so much, Dr. Ansari. And I think that we still have a crowd on Zoom and we have a crowd here in person. So I think we're good to take questions. Folks online, please feel free to use the chat function or raise hand feature. Any questions from folks here in the room so far? You're getting some love in the chat, David. I can start us off if that's cool with a question. Thank you so much for this. I think that this is really incredible and we need to be having, I think, more discussions as just a health sciences enterprise here with 7 different health sciences schools and colleges in terms of what kind of materials our students are getting in their classes. So given that, I think one of the questions I've had and has been even, I think, made more obvious with your presentation is what things do you think that we can implement right now as, say, in the College of Medicine to ensure that students are getting this curriculum, not just by coming to your talk and learning about it, but actually in their training throughout the 4 years? Is it a mandatory class? Is it something that's interwoven throughout their curriculum? Is it more of these co-curricular lectures? If you had all the power, all the money, all the resources in the world to kind of be able to change what the curriculum looks like for medical students, where would you begin?
Thank you. You know, I hesitate with ever like thinking of like a mandatory class because I worry that like when you render something mandatory, then
Yeah.
it makes it like not only less fun, but it kind of creates a different uh power structure around it, which is part of what's at stake here. I think one really like straightforward way is really to think about mentoring and how important mentorship is, which is something that like consistently across all of these studies, which are very different from one another, has been like a consistent theme of like feeling that one not only has someone that they can turn to, but that's someone that they identify with. So, for instance, you know, with the folks who are the psychotherapists in France, being able to have difficult conversations and say, you know, I feel like I'm being utilized in a tokenistic way, and like here I am representing diversity, but when I actually want to say something, no one's listening or they're changing the meaning of it, and having someone to talk to about that. Or similarly, you know, when people want to raise something that could be, you know, potentially quite critical, feeling that they have like someone that they can turn to who you know is open to having difficult conversations. And then I think, you know, for the first generation students in medicine, also we're talking about the importance of just having people who they could turn to for all of the kinds of things that were not only hidden and out of sight for them, but being able to process some of the more difficult experiences of exclusion that they had as well. So I think like a really straightforward way, at least initially, is
Mhm.
through mentorship.
Perfect. Thank you. That was certainly seen in all of your stories. So thank you for that. I know we're losing a couple people online. So Cassandra is going to put into the chat a feedback form. So please feel free to fill that out as we kind of adjust and pivot here in the center based off of feedback that we get. So it's completely anonymous and shouldn't take more than 2 minutes of your time. We really appreciate it. Other thoughts, other questions? Yes.
Wonderful talk, David. I was very curious about what you meant by the haunted curriculum, so thank you for sharing your work. I'm kind of curious. It seems like these experiences are highly personal. For each individual, they all come with their own background. You know, just because one person from Tunisia, as you demonstrated, doesn't mean they all share the same sort of perspective on what that identity means for them. So I'm curious about how prescriptive we ought to be in terms of designing educational experiences for the learners versus how much do we need to just simply be a supporting force that sort of says everyone will experience things differently, but these are some resources that may help and they may not help. I mean, how far can we go? How far should we go?
Thank you. I think that's a really great point and question, and I thank you for that. And I think that really much of it is the kind of latter point that you raised about like being there to support and to listen to people and their experiences and not to be overly prescriptive. There's something else I wanted to add to it, but I'm kind of losing it right now. But I appreciate that. Thank you.
Wonderful. Thank you. Other questions? Yes.
I'll just echo Jeff's point, which I was really wanting to hear you sort of articulate what's going on with this. And I really appreciate being able to understand this concept more fully. Um, I I really liked that you talked so much about the relationship between the hidden and the haunted curriculum here. And I wondered if you could talk a little bit more. I know that when we talk about the hidden curriculum, one of the things we talk about is um, providing, sliding that curtain back and showing students what's going on with that hidden curriculum. And you talked about how that's not something we need to do in the same way, or we should be doing in the same way with the haunted curriculum. So I wonder if you can talk a little bit more, or maybe I misunderstood that part. So maybe you could talk a little bit more about how that works with the haunted curriculum. Like, there's sort of, I don't always agree that sliding the curtain back is the solution for hidden curriculum either. But I wonder if you could talk a little bit more about how um, that works here. And given Jeff's really excellent point about the sort of the different ways that each individual student engages with the haunted curriculum, like which is different, I think, than the hidden curriculum. How does that? How do they relate? I guess is what I'm trying to. Can you just go a little higher up for us, for those of us who are brand new to this construct? Does
Sure.
that make
Thank you.
sense? Yeah.
Yeah, of course. Thank you so much. Yeah, I mean, I think one of the parts that really strikes me as the important both link and distinction between hidden and haunted here is that hidden kind of, as you said, kind of assumes that there's like something that needs to be rendered explicit, something that needs to be pulled back. And the haunted, I think, is less about is less about certain things are out of view, because for some people they're very, very obvious and they're very experiential. And so it's less about trying to reveal something and more about sitting with. And that's kind of why I like, talking about like ghosts and specters, even though it sounds a little bit weird in this context. It's like, if we think about sitting with something that's uncomfortable and engaging with something that's uncomfortable, that is something that does kind of capture what Jeffrey was saying about the kind of individual experiences of it and how people experience, different aspects of clinical training and the formation of expertise differently, is about creating that space for people to be able to sit with things in their own kind of personal way. Um, I just want to give one quick example. This is kind of something that maybe some people saw in the New York Times. I think it was last week, about the unbearable vagueness of medical professionalism. And we could have a whole conversation about medical professionalism. But when I read this, I thought, oh my God, this is like kind of exactly what what I think is at stake here, is that not only is there sort of like a lot of vagueness about what professionalism means, but also what being unprofessional means. And what is really, I think, important here is that we see that there can be a kind of like over policing of certain students and certain residents, for instance. But one could say, like, okay, well, with a hidden curriculum, there's certain things about what it means to be a professional that are not accessible to everyone else. And the haunted curriculum is like, well, actually, no, there are also these very outdated ways of viewing professionalism that lurk within spaces of clinical training, and we actually need to engage with those. It's not just simply uncovering what we mean by professionalism, but it also means engaging with some of the darker meanings around what we associate to be unprofessional. So I saw this and I thought this is like a really kind of like a very clear way to see, like, okay, hidden is great, but there's more that can be done with haunted. No,
Thank you. Anyone? I know that we have a lot of people here in person asking questions. Anyone online, feel free to also unmute. We can hear you in the center too. If anyone online has any questions, we welcome them now. In the meantime, I can ask another one. One of based off of that, I was just recently having a conversation with some leadership here on the health science campus and discussing professionalism and how there's been a lot of pushback from students on leadership using that term. And professors and leaders are like, but what do we do? What do we use? This is what we've used for forever. And I'm curious on your thoughts. One of the words that I've advocated for in the past is to use the word integrity. And I think to myself, if there would be leadership at this point being like, oh, you're acting unprofessional, I almost do an eye roll because I feel very similar to not the most positive connotation to the word professionalism. But if someone tells me you lack integrity, whew, that that I'm like, let's have a conversation. That's not something that I want to be as a leader, as an academic, as a clinical provider, as a student, as anything. So that's just an example of something that I've used in the past with leadership. Do you have other suggestions or other thoughts on what language to use here? Because I really think that a lot of people are grappling with this, both students and also leadership.
Thank you. I think that's really a great example. And yeah, I think the focus on integrity versus professionalism, is really powerful. And I think, it conjures different meanings and has, I think, different stakes. I'd have to think a little bit more about other examples, but I do see that as like a potential direction to at least kind of, as I was saying before, like with engaging with like the ghosts or the things, like to actually sit with things that are uncomfortable, that being able to have a discussion about like what integrity means and what the consequences are, I think is something that's much more explicit than something like professionalism.
Absolutely. Thank you for that. I think that it too, with the word professional, in the ideal world, as educators on this campus, we don't want our students to just turn this on for the sake of like their professional education. Like we want them to be good people outside of just school or outside of just clinical practice. And I think the word integrity ties more to who you are as a person, as you go through life, as you engage in various relationships with people, both inside and outside of academia or healthcare. And I think ultimately that's what we should be trying to do. We shouldn't be trying to get people to just think about the professionalism with like inside a clinical setting or inside a classroom setting. Another example too that I've seen that I'm curious to hear your thoughts on. I'll stop first. Anyone in the chat? Anyone else on here in person? Questions? I can offer this as kind of the final question. Please do fill out the feedback form. We really appreciate it. When thinking about oh my God, I feel like I just lost my thought.
Happens to me all the time.
I just lost my thought. What was it? We'll just end it there, David. I think we're good, but please, if you hit one more, people online can also, here in person, can fill out the feedback form. But thank you so much. Thank you so much, David. I will go ahead and sign us out. This miigwech, this is one way to express thank you in Potawatomi. It expresses a desire to reciprocate in the future. Thank you, Dr. Ansari, and thank you to the Odeh Center team, Cassandra, Samina, and our OVCHA partners, Michael and Brian. Bama Pimain, or until another time, because in Potawatomi, there is no word for farewell, as we expect to see each other again sometime soon. Thank you everyone online for joining. Thank you everyone in person, and please a round of applause again for Dr. Ansari. Thank you so much.